Max, Program Manager for the California Opioid Safety Network at the Center for Health Leadership and Practice, a program of the Public Health Institute. You are about to watch a webinar that has been condensed from its original format to provide specific content regarding strategies to lower opioid demand. During the webinar, we will cover trends, existing strategies, and lessons from the field. The subject matter expert for this webinar is Dr. Matt Willis, our clinical lead for the California Opioid Safety Network. Let's get started.
Our vision is zero opioid overdoses. And to get there, we know that we need to be addressing simultaneously the problems of supply and availability, high opioid demand, and take new steps to prevent overdoses in real time. Why is it important to reduce the demand of opioids? This is the latest data that's come out of the CDC and offered some somewhat discouraging news around the acceleration of the opioid epidemic nationally. 2016 saw the greatest rise in opioid overdose deaths of any year that had preceded it. The primary contributor is the orange line, which is other synthetic opioids, particularly fentanyl. Fentanyl has accelerated significantly, so the epidemic is gaining in scope but also in complexity. To understand the context and framing for addressing demand, it's important to just revisit that question of how we got here. This has been called an epidemic of despair, which is described nicely in Sam Quinones' book, Dreamland. Heroin and fentanyl are on the rise. Fentanyl is difficult to control because it's coming in through the dark web. It can be obtained through the internet, and obviously manufacturing in China and Mexico has been made the supply side even more complex to try and control. And finally, on top of that, we really don't still have the infrastructure necessary to address all of those individuals who are struggling with opioid dependence and addiction. The CDC has been starting to talk about phases of the opioid epidemic. This is really primarily a problem of prescription opioids due to ever-increasing opioid prescribing rates and a corresponding increase in people with dependence and addiction. Phase 2 began in 2012, where we started seeing more heroin incidents, and you can see that on the overdose death trends. And then Phase 3 is very recent. Around 2016, we started seeing rapid acceleration in fentanyl. So controlling the supply side with increasing availability of fentanyl and illicit opioids is even more challenging, perhaps, than the work we've been doing to control the prescription opioids. And we're seeking to be data-driven and evidence-based in our approaches, both to inform our strategies and to monitor our progress. And to plug every chance I get, the use of the California Opioid Dashboard. One of the indicators on the dashboard that's helpful to your efforts in terms of evaluating progress relative to MAT is the buprenorphine prescribing rates that are available to all counties down to the zip code level, as shown here. And encouragingly, we're seeing steady progress in most areas there and across the state as a whole. And then another important indicator that has been added to the dashboard is fentanyl. Because fentanyl, when it's used in the community, is primarily illicit, it doesn't appear on the cures database, so it's difficult to track the supply of fentanyl. But you can see the impact of fentanyl in the new functionality on the dashboard of fentanyl-related overdoses for your community. In terms of measuring the burden in your community, the Urban Institute recently developed a set of fact sheets for each county that offers an estimate of the number of individuals within your county who are suffering from opioid use disorder, A, and B, the proportion of those who are actually tied into treatment, and offers a numerical estimate of the number of people who do not have access to treatment for opioid use disorder who should. Obviously, we want to acknowledge that the most sustainable method here would be actually preventing occurrence of addiction and dependence itself. These are examples here of some of the materials that RxSafe Marin has developed for our public-facing campaign. Many of these are posted in clinics throughout the county and have been effective in sort of changing community norms and stimulating new conversations. Social media is another way to reach the population as a whole, again, recognizing that we need to be not only changing our healthcare practices, but making this essentially a social movement. This is the California Healthy Kids Survey that we've used within Marin to say that 1 in 5 of our young people have used painkillers recreationally, and that in itself really sort of stimulated a lot of local concern. The next strategy to acknowledge is reducing stigma. Stigma itself is one of the drivers of perpetuating the epidemic, and that it is its direct effect on individuals who are suffering from opioid use disorder as shame and not asserting their right to treatment, and maybe not talking about their issue or seeking care. One of the ways of reducing stigma is to local faces and local stories be part of the strategy. So we want to make sure that the communities themselves are understanding the burden within their own context, and that voices from within that community who may be suffering from addiction are able to share that story in ways that make it clear that it's part of the fabric of our own communities. Another important strategy for reducing stigma, and these are slides from Kelly Pfeiffer of the California Healthcare Foundation, is comparison to other conditions, other chronic conditions which are much less stigmatized. We're comparing addiction to diabetes. So we have a lot of work to do in terms of framing addiction as a chronic disease, which are words we use now, but our systems don't reflect that understanding. Another important driver of demand is the way in which pain is treated with opioids, especially the use of high-dose opioids for the management of chronic pain. The CDC has started endorsing non-opioid methods for the management of pain, and there are resources available at the CDC. On this infographic, they say that 1 in 4 people who receiving prescription opioids for chronic pain in primary care actually are struggling with addiction, and that non-opioids like NSAIDs, Tylenol, antidepressants, and anticonvulsants can often be just as effective, as well as non-pharmacologic methods like physical therapy, exercise, and cognitive behavioral therapy. In Marin County, we did a survey just to determine what the appetite locally was for understanding non-opioid methods, and we found that both among our community members and among our providers, there was a lot of interest in promoting non-opioid alternatives. And based on that, we had a community-wide forum last month that was dedicated to healthy pain management. This was put together by California Healthcare Foundation, looking across, almost a meta-analysis of looking across a variety of studies to show that methadone, buprenorphine, naltrexone are all much more successful as strategies for addressing opioid addiction than treatment without medications. Because the supply side of the issue is getting more complex with greater availability of fentanyl and other volatile and high-potent opioids, we need to make sure that it's easier for people to access MAT than illicit opioids for people with addiction. Look what happened in France in the 1990s. They were seeing increases in heroin overdose deaths up until about 1994. They basically changed the game completely around buprenorphine by making it much more easy to prescribe and access. There was no special waiver process. It was not a segmented and separate activity. Addiction treatment was actually integrated much more into primary care. Buprenorphine was essentially normalized in some ways, and the prescriptions of buprenorphine increased dramatically over a short period of time, with a corresponding decrease in heroin overdose deaths. So that's the kind of massive, I think, social and clinical change we need to be looking for in our approach to medication-assisted treatment. One important way to think about this and organize our thoughts around connecting people to addiction treatment is to recognize the sequence for an individual who has moved from addiction into treatment. What were the necessary steps for that to occur? And they're drawn out here. And it's important to see that if any one of these things is not in place, that individual with opioid use disorder will not actually get into treatment. So all of these things need to occur in every community for us to close the treatment gap. So on the far left, we have opioid use disorder develops and an addiction develops. We need to recognize that when first was a failure to prevent that from occurring, and that person is at risk for overdose. The next thing that has to occur is that individual needs to be recognized as such, as someone with opioid use disorder, which can happen ideally in a clinical setting or someone else in the community who is empowered to see the signs and recognize the signs and offer treatment or referral, or that the patient themselves are aware and they seek help. Second, that the treatment be offered and accepted by the patient So the provider has to be empowered to act upon that knowledge if they do screen someone as positive. They can either initiate treatment or refer, and the client is able to access and accept care. Third, that the referral actually is successful. So the linkage is in place to the treatment option. And then finally, that the treatment itself begins, that there's sufficient local treatment capacity, and recognizing that people may relapse, fall out of treatment, and need to have that system perhaps reinitiated for them all the way through. So to summarize that, we need to be identifying patients, we need to be referring them, and we need to be treating them. And it's a suggestion that we begin to map out the touch points within our communities where people with opioid use disorder are actually touching the system, which includes our first responders, our primary care clinics, mental health and addiction treatment services, first responders, health plans and medical societies, pharmacies, law enforcement, jails and corrections, school and academic institutions, public health, healthcare providers, hospitals, and clinics. So all of those are potentially partners in expanding our screening process across the community for identifying individuals. And in Marin County, we just started a process where we're using our first responders, our EMS system, and looking at EMS 911 records to look at opioid overdose events and reaching back to survivors of those events to try and tie them into treatment. Many of you are aware of the hub and spoke model. This is a federally endorsed and supported strategy to address that continuum of need across the system for tying people into medication-assisted treatment. And the final strategy to reduce demand that we'll be addressing on the call is increasing treatment capacity. So we're going to start with introducing Dr. David Kahn. Dr. Kahn is the Medical Director of Bright Heart Health and President of the California Society of Addiction Medicine. He's a clinical faculty member with UCSF, and he's a psychiatrist certified in addiction medicine.
Once again, David Kahn. I'm a psychiatrist by training, board certified in addiction medicine, and I wanted to talk today for a few minutes about what we've learned from the field around doing telemedicine for medication-assisted treatment. There have actually been studies looking at telemedicine and in-person treatment for opioid use disorder, and it turns out that the outcomes are generally same or similar, sometimes slightly favoring telemedicine. But the patient satisfaction is dramatically improved. And if we think about the number of mobile devices, there's far more of those than there are hospital beds in the United States. So telemedicine really is poised to explode at this point in time. To refer patients to Bright Heart Health, you can either go to the website, email, we have a secure texting option. And our treatment includes MAT. And by medications, we're talking about buprenorphine primarily, but we also use naltrexone where indicated. We also have care management, counseling, individual as well as group, and we have the full spectrum of services from engagement all the way up to intensive outpatient programs. One of the things that we have is an app. We take a community health approach, meaning that we recognize that there's many inputs into the system. If we do the outreach across the system, we're more likely to catch people at varying points of readiness, whether it's ED hospitals, behavioral health, drug courts, corrections. These are all doors in which you can get into care with Bright Heart. But there's many opportunities to intervene. We know the number of people out there, and the emergency department turns out to be a prime location to interact with patients. When we interact with the emergency department, we can either do telemedicine directly in the emergency department or the clinic. This is a list of some of the emergency departments that we have relationships with. I wanted to go through a case study, and this is through the Community Hospital of the Monterey Peninsula. We trained the ED staff, distributed handouts, put posters out there to let people know about our services. And to date, we've had more than 25 intervention and referrals. Remarkably, 100% of the patients from the point of getting buprenorphine in the ED. And if we look at our retention rates at 30 days, we had an excess of 95% of retention. And so this is a very practical example of how we were able to deploy into an emergency department a hotspot of sorts and connect people to the seamless continuum of care. Thank you.
Thank you so much, David. For the purposes of this webinar on reducing demand, we recognize that telehealth is a really emerging and important tool for us, and that Bright Heart Health is among a number of telehealth options. But just want to be clear, we're not officially endorsing any one product. Next, I'd like to introduce Brian Hurley. Brian is an addiction psychiatrist and medical director of the Co-Occurring Disorder Services at Los Angeles County Department of Mental Health. Brian will be talking to us about the work that he's been doing through the SafeMed LA Opioid Safety Coalition to increase access to MAT in their clinics.
So as was mentioned, I co-chair the Medications for Addiction Treatment Action Team. It's one of actually a number of the action teams in SafeMed LA, which is LA County's local coalition. And I should just mention here, the term that people use a lot is medication-assisted treatment. I actually have been promoting the use of medications for addiction treatment. And the vision for the way that we're planning to do medications for addiction treatment in LA is really expand the capacity to provide medications for addiction treatment at all health sites. So by all health sites, I mean community health centers, hospitals, emergency rooms, community mental health centers, correctional health services, be able to link people from field-based services to treatment providers that offer medications for addiction treatment. So the conceptual framework is actually really relatively simple: to get clinicians ready to prescribe, patients willing to participate, and organizations that are capable of actually delivering these services. And there's a pretty good study that was published last year out of Venice Family Clinic, which is one of the federally qualified community health centers in Venice, California. Kate Watkins was the primary investigator on the study. It takes a lot more than training to actually develop a system that delivers evidence-based treatment. So certainly, supportive and knowledgeable leadership and staff is critical, and training is important for that. She also identified that having technical assistance and experts available for consultation, treatment protocols, parameters, those things create the context where, say, an X-waiver prescriber is going to actually then use that X-waiver to offer buprenorphine. And then, of course, delivery system redesign. She also found that patient self-management materials and linkage to community resources and a registry was also really relevant to getting an organization to really embrace the delivery of medications for addiction treatment. And I have to give credit to Dr. Khan and the California Society of Addiction Medicine for really pushing the state to include access to buprenorphine on the Medi-Cal formulary. One of the things that I helped participate in was getting naltrexone long-acting injection approved on the Medi-Cal formulary as a pharmacy benefit. You have to be able to address those government insurance and payer policies in order to be able to actually, advance medications for addiction treatment. And then there's all these logistic issues that need to be addressed, like which pharmacy is going to take care of your patient. So we build systems that segregate physical health from mental health from substance use disorder treatment. And so patients tend to think, oh, I'm going to go to my primary care doctor, which is going to help me with my hypertension or diabetes or my asthma, but they're not going to be able to help me with my opiate use disorder. Not because they can't, but because the patient has that in their mind that in a system that segregates these services. There's actually a document I just want to promote, and it's the ARC, Medication-Assisted Treatment Models for Care for Opiate Use Disorder in Primary Care Settings, common success factors for the delivery of opiate use disorder care in primary care, articulated in this document that has been really helpful for us here in LA County. So in our county, we have tremendous silo issues in the extent that you have different people regulating, funding, and managing care in the physical health, mental health, and substance use disorder treatment sector. Recognizing this, the LA County Board of Supervisors actually directed not just the county health agency, but really the whole body of county departments to create an initiative on the HEART Collaborative, Help for Addiction Recovery and Treatment, that has become a collaborative between the LA County Sheriff's Department, Fire Department, our coroner and medical examiner, our district attorney, and then through the three health departments through the county health agency. And it has been tremendously helpful because we're able to talk to the coroner about what are you seeing regarding fentanyl. And that's helped us think through the data we're seeing. We were able to get naloxone in the hands of all of our sheriff deputies that are out in the field. We're working with the district attorney about thinking about a rational way of connecting people when they're being charged for drug-related offenses, of connecting people to treatment, and then, of course, wanting to build capacity for medications for addiction treatment in any health-facing department. So our systemic facilitators and the things our medications for addiction treatment action team has been really focused on is making sure that all of our county departments have formularies that include all of the medications for addiction treatment when appropriate. that we develop standardized practice documents and that we distribute those policies, practices, and procedures. But probably the biggest area of work in our Medications for Addiction Treatment Action Team has been expanding provider readiness. So we run buprenorphine waiver training several times a month. I should mention that the drug Medi-Cal waiver, the 1150 waiver in our state in LA County was operationalized to create a 24-hour phone line. So anybody can call 24 hours, 7 days a week to look for just opiate treatment programs or just programs that are capable of using medications for addiction treatment. You can use the filter bar. And you can also segment by population. So I want a male bed or a bed for somebody who identifies as LGBT or so forth. This tool can help you with that. And it's a publicly available website. So we have the service and bed availability tool that anybody could go on and look at the treatment options that are available here in Los Angeles. The Department of Public Health also created this Medications for Addiction Treatment Resource Library in partnership with UCLA that includes a whole number of really practical protocol you use or consent form you use or what's your process for toxicology. But there's this whole list of resources geared towards providers, geared towards patients, and it's, again, publicly available. We offer through something called eConsult, an addiction medicine eConsult portal where people can get expert consultation on medications for addiction treatment. We finally got buprenorphine on the formulary and are busily working as part of a newly created addiction medicine service to actually make medications for addiction treatment available to the huge numbers of people with alcohol, opioid, and tobacco use disorders that come through 4 jail facilities in LA, but come through one of those correctional health facilities.
I'm going to end with just this, inspiration that we can look back to in our own nation in 1995. The AIDS epidemic was the defining health crisis of that time, just as the opioid epidemic is now. In 1995, there was 50,000 deaths to AIDS. We had 42,000 opioid-related deaths last year, which is 5 every hour. So in the last hour that we've been having this conversation, at least 5 people have died from the opioid epidemic in the U.S., which is sobering to think about. And if we think about what changed to help us get in front of the AIDS epidemic, a lot of those strategies apply to what we're dealing with here with opioids. Remember that kids with AIDS were barred from schools, and misunderstanding about AIDS left a lot of people ostracized and alone. Then a couple things changed. We got wide availability of effective medications and a broad anti-stigma campaign. Rock Hudson, Magic Johnson came forward to see AIDS as a disease and not as a character flaw or a moral issue. And we made antiretrovirals widely available and had massive campaigns to make sure that every single person with HIV had access to the treatment they deserved. And we saw corresponding rapid decreases in viral loads and death related to AIDS. And so I think that's our collective goal and mission, is to try and promote that kind of broad social change and healthcare change that led us to get in front of the AIDS epidemic.
Thank you for watching this video. Please visit our website, CaliforniaOpioidSafetyNetwork.org, to access tools and resources, information on funding opportunities, and more videos in this learning series on opioid safety strategies and coalition development.